Today I'll be showing 4 cases of different subsets of acute pulmonary embolism. So the first case is a 79-year-old female patient, diabetic, hypertensive, presented with a severe breathlessness, sudden onset, orthopnea, cough with expectoration. Her hemoglobin was 9.6 grams per deciliter, serum creatinine 0.63, elevated NT-proBNP 9,307, elevated tropi 2.5 nanograms per ml, D-dimer 3,493, systolic blood pressure 100, heart rate 126, and SpO2 85 without any oxygen support. So patient is having a elevated D-dimer, elevated NT-proBNP, and sinus tachycardia with hypoxia. So ECG is having a sinus tachycardia. Apart from, there are no other changes. Echo showed dilated RARV with RV dysfunction and severe PH. So CTPA was done outside, which revealed thrombus in the right pulmonary artery, right upper middle lobar arteries, left upper lobar pulmonary arteries. So based upon this, we are classifying this one as a intermediate high risk group. High risk group, you should consider, this is based upon the recent ESC guideline 2019. And if hemodynamic instability is there or not, if hemodynamically unstable, and if the blood pressure is less than 90, previous, as per the ACC guidelines, it's like a massive or submassive. This comes under submassive. So blood pressure normal. This is intermediate high risk because hemodynamically is stable, but patient is also having a PESI score more than 1 because hypoxia is there and almost 80 years, and RV dysfunction is there and elevated troponin. So she comes under intermediate high risk group. So suppose if there is no hemodynamic instability and RV dysfunction is not there, only either trop or this one is there, that comes under intermediate low risk group. If none of the features are there, no hemodynamic instability and PESI score is less than 1 and RV dysfunction is not there and elevated tropi and is not there, that comes under low risk group. So reasons to consider clot clearance, why it's very important, particularly if it is a very massive thrombus, it treats the acute hemodynamic because reverses the abnormal, because flow is better than preload on the afterload on the RV will be later. So reverses the abnormal hemodynamics, lowers the mortality rate, and reverse acute and subacute right ventricular dysfunction, and prevents the chronic thromboembolic induced pulmonary hypertension. Suppose you have not treated, so it gets organized, and multiple thrombi also can lead to chronic thromboembolic hypertension. So these are all very important. So the chronic thromboembolic pulmonary hypertension is seen in almost 4% of survivors of acute PE, and untreated CTPH has a 90% mortality. So always treat early during acute pulmonary embolism. You try to clear the thrombus as much as possible to prevent this complication. And what are the treatment options in acute? This patient comes under intermediate high risk. Thrombolytic therapy, let us discuss. And because as per the guidelines, only indicated in a massive or high risk group where there is hemodynamic instability. And anticoagulant therapy, heparin versus low molecular weight heparin or fondaparinux. Oral anticoagulants, vitamin K anticoagulants are novel oral anticoagulants. And ventilator support not required for these patients. Circulatory support is not required for, unless they deteriorate. And here, what are the recommendations for intermediate or low risk PE? Initiation of anticoagulants is must. And parenterally, you prefer the low molecular weight heparin or fondaparinux. These are preferred over unfractionated for most patients. And compared to vitamin K, prefer the novel or anyone you can choose, apixaban, dabigatran, edoxaban not available in India, rivaroxaban, anyone you can choose. These comes under class 1A. So intermediate group. As such, routine use of primary systemic thrombolysis is not recommended. Class 3B. Only rescue thrombolysis therapy is recommended for patients with hemodynamic deterioration. So you try to treat these patients with anticoagulants, but if they deteriorate and if the symptoms are not subsiding, if the gradual deterioration, that time you can think of the thrombolytic therapy. So this initially anticoagulant therapy followed by NOAC, but treated with the thrombolytic therapy due to worsening and no relief of cardiovascular symptoms. So post thrombolysis, you see the large thrombus. You can see very big thrombus. Still, residual thrombus is there in the right pulmonary artery and proximal and upper and lower branches. So we gave thrombolytic therapy, systemic thrombolysis. What next? We have to think. Shall we go with only anticoagulants? Or is there any role of catheter-direct thrombolysis? Or is there any catheter-direct therapy versus thrombus aspiration? If you are doing a thrombus aspiration, is it necessary to do only simple manual aspiration or mechanical aspiration? Is there a need of surgical option? Here, surgical option should not be considered. Why? Because the patient is a stable condition, no cardiovascular, no hemodynamic deterioration. So in such case, either go with the conservative or you can think of CDT or thrombus aspiration. So catheter-based therapies are either simple, you can take the Fontan catheter and you can make a multiple holes in the multipurpose catheter, you can perfuse the thrombus, or pharmacomechanical or sonic assisted. These are different devices, different techniques. And then we access the right femoral venous access and multipurpose catheter, mainly to place the thermo wire, and then exchange with the superstiff. This is a pulmonary angio, you can see very clearly. Right side, there is a huge thrombus. It's a right pulmonary artery, almost total. If you leave this one, definitely patient can go into chronic pulmonary hypertension, and definitely it affects the right lung significantly because main pulmonary artery, right pulmonary artery is involved in the beginning. So then we thought of using Indigo catheter, right PA over this aspiration, mechanical aspiration catheter. So this is a catheter. How does it works? So then mechanical, this engage the mechanical clot engagement, and it 8 French sheath. It's a 8 French delivery catheter, and you can see very clear aspiration catheter, which needs 9 French or 410 French, and it aspirates with force. That is very, very important. So if you see the almost only simple to operate, only one touch button. And if you see here, a full vacuum generates up to 90% more suction with Indigo compared to the manual suction, because the suction is more, the suction power is more, then it can aspirate thrombus more accurately. So this is an example of thrombus aspiration, and totally occluded, and after that you can see the perfusion. So another system which is available in India, in addition to Indigo, the Angiogen system is also there. This is a quick restoration of the blood, improve vessel and target lesion visualization, and decrease the risk of distal embolization and resulting complication. That may lead to pulmonary infarction, that may decrease the pulmonary lung function also. Option of pharmacomechanical. So you can combine aspiration and simultaneously you can give a thrombotherapy. This pump generates about 10,000 psi to push the saline through the jet tube. It's like it acts through the Venturi effect. The jets are directed backwards at high speed. The saline escapes from the outflow window of the catheter and acts to loosen the thrombus and draw it toward the inflow windows. That is called entrainment. This thrombus is then captured through the inflow window, fragmented within the angiojet catheter and evacuated through. So it produces more effective thrombolysis. You see, after the Indigo, we are aspirated, then we are giving a check injection. This thrombus, almost 70% thrombus clearance, but still 30% still remaining. So then what we thought, see, now you can see almost compared to earlier, there is a significant resolution of the thrombus. Then we thought of putting the Fountain catheter. There's a Cook company's perfusion catheter. It will have multiple holes, right pulmonary artery, and through this, just we gave catheter therapy for 24 hours to produce some more effective thrombolysis inside the thrombus to clear the total thrombus. So fourth day we did the echo, then still RV pressure was there. Sometimes it takes time to, you continue the anticoagulant, gradually it will fall, but the patient significantly improved and hemodynamically patient symptoms subsided and patient was feeling comfort, breathless, everything subsided. You can see the hypokinesis of the RV and you can see that TR jet is there. You can see RV is dilated. So this is significant thrombus. So if you leave it, the patient can show further worsening and ultimate deterioration. And today at the time of discharge, compared to that one, you see right ventricle significantly improved. Previous echo showed a significantly improved RV function. RV size also decreased and the TR jet also significantly reduced. So the thrombolysis definitely plays a big role. Either give a systemic or you can give a through mechanical aspiration plus or catheter thrombolysis you can try. And she's on follow-up for the past 1.5 years and she's on rivaroxaban 50 milligram annually. So once you treat these patients when you are discharging, how long we should maintain anticoagulant therapy? Is it for 3 months or 12 months or an indefinite period? So during follow-up, always check the ECGs and in between check the NT-proBNP for any RV dysfunction leading to RV failure, RPH leading to RV dysfunction failure, and 2-day assessment of the right ventricle and pulmonary function, CT pulmonary angio, and always check for symptoms and signs of any pulmonary artery hypertension and RV dysfunction, any bleeding complications with oral anticoagulants there or not. Another thing, easy taking adequate drugs or not. So compliance with the drugs are very, very important. Suppose if the patient developed unprovoked pulmonary embolism, if he's not using drugs, there is a chance of recurrence of pulmonary embolism. So these are the low molecular weight. You can choose any one. After thrombotherapy, you can standard many of the time we use enoxaparin. And the recommendations for the regimen duration of this is not needed for this relevant topic. So always suppose if, minimum you give for 3 months period. Suppose if there is a precipitating cause is there, a reason for the immobilization is there, recent surgery is there. In such cases, you can continue. Unprovoked is there or recurrent thromboembolism is there. That time you continue for indefinite period. That is a very, very important. The second case, 49-year-old male, known hypertensive, presented with a recent history of sudden onset of breathlessness and cough with progressive symptoms. Heart rate 126, blood pressure 100/70. ECG showed sinus tachycardia. 2-day echo dilated RARV with RV dysfunction. Elevated D-dimer, TROP-I elevated, NT-proBNP. CTPA showed submassive acute pulmonary embolism. Our plan is to go with always check the TROP-I. So 50% of the patients will have, acute PE patients will have a elevated TROP-I. There is meta-analysis. This was conducted between 98 and 2000. The studies which were published between 1998 and 2000, they collected 1985 patients. It showed it is associated with increased risk of death and major events in the acute phase. So that's the reason, never forget to do TROP-I, echo, and NT-proBNP. These three are the predictors. Blood pressure, hemodynamic unstable, very high risk. Irrespective of this patient comes under very, very, event rate is very high. Mortality rate with a massive or high risk group, almost 50%. Intermediate group, it's about 21%. If it is low risk group, it's about 5 to 6%. So that is the reason, classify. Hemodynamic instability top priority. If hemodynamic instability is not there, dilated RA, RV dysfunction is there, elevated TROP-I is there, elevated NT-proBNP, these come under high risk intermediate group, intermediate high risk. So such patients should be monitored. And if there is a deteriorate, you also think of giving a thrombotherapy. So NT-proBNP also, meta-analysis of 13 studies. This is also positive in almost 51% of 1132 study population. And this is also indicated very high event rate when it is elevated. Higher the value, higher the risk. So PESI score also simple, simple to analyze. You see age more than 80, history of cancer is there, history of heart failure. One point to each, like age more than 8, 1 point, history of cancer 1 point. So you just calculate the total number. If more than 1, definitely comes under high risk. So resting saturation more, less than 90, definitely they come under risk group. So if none of the factors are there, definitely they come under low risk. So then we did the angiogram. Then you can see the right ventricular angiogram, and you can see here left pulmonary artery totally occluded. You are able to see the right pulmonary artery. So left pulmonary artery totally occluded. We are unable to see it. The left lung is not having any flow. So our plan is, because to produce a more effective thrombolysis, then we put the sometimes you can put the pigtail, and through pigtail also you can give the thrombolytherapy, and just wait for a few minutes. Many times, so half an hour, if you wait, it will respond, it will open. If that is not open, then you can put the fountain catheter and perfuse for 24 hours. You see now nicely opened after giving intrapulmonary thrombolytherapy. So this is a view. You see the right ventricle, this is the left ventricle, and there is a hypokinesia, but there is a significantly improved RV function, and almost the size of the RV is regressed, and you can see nicely, very important. Only mild dilatation you are able to see, and TR also significantly less. And you see, this is 3-year follow-up. Always during follow-up, you check whether with the RV and everything. And RV significantly, you can see here, RV significantly, size is decreased, RV function is normal, there is no TR. And this is another case, 21-year-old male, ex-smoker, acute onset of chest pain, and breathlessness of class 3, associated with sweating and high-grade fever on and off. ECG showed sinus tachycardia and elevated biochemical markers. Again, ECG can mislead. The classical ECG, what you see, that is S1, Q3, T3, that is seen in only 30% of the patients. But once it is there, many times that can predict the pulmonary embolism. But that finding you see, this is S1, Q3, T3. You can see S wave, and you can see the Q wave and T inversion. This is classical of acute pulmonary embolism. When you see, and at the same time, many times the patients will have a sinus tachycardia, T wave changes may be there, STT changes may be there, non-specific STT changes, right axis deviation, RBB may be there, P pulmonary. But if you see this finding, always a patient without any significant coronary ECG changes, and echo is not showing any significant RWMA of LV, the patient is having a RV hypokinesia, dilated RARV, always think of the pulmonary embolism. You see here, you can see a dilated right ventricle and free-floating thrombus in the right atrium. Rarely you see this type of picture. So right atrium, and this is migrated to pulmonary artery that led to pulmonary embolism. You see that there is a TR, and you are seeing the freely floating. Initially, we thought, is it left atrial myxoma, like a two tumors, what we thought. Their TR is there. Then we were in dilemma whether to give a thrombolytherapy or not. TRAPI is elevated. That is also NT-proBNP, because once the failure is there, RV pressure is elevated, NT-proBNP may be elevated. So here, if you see the pressure, the pre-gradient is 52, mean gradient 31. So there is a significant pH is there, dilated RARV, mild TR. So then we have to see the measurements. Always see the RV and LV diameter. If RV diameter, how to, it has some importance. So when you see the transthoracic echo, RV dilatation is there or not, you measure the LV and RV ratio. If more than 1, McConnell sign, that is the RV pre-wall hypokinesia. If that is there, that is the indicative of, if there is no other reason to explain, that is a class, sudden onset of dyspnea, acute chest pain classically indicates pulmonary embolism. If you see the parasternal short axis, it's a flattened septum. And you may, because RA pressure is so high, patient may have a IVC, plethora, and absence of inspiratory collapse. Patient may have a raised JVP, and RVS3 you may see in such patients. This is 60-60 sign, where the coexistence of acceleration time is less than 60 milliseconds and mildly elevated systolic gradient at the tricuspid, that is usually less than 60 millimeters. So that is 60-60 sign. And another one is right heart mobile thrombus. Here, this patient is showing a mobile thrombus in the right atrium. Sometimes you may say in the right ventricle, or tricky tricuspid annular plane systolic exertion, because this hypokinetic, it's a dysfunction is there, its movement is not there. So that will be less than 16 millimeters. Another one, the tissue Doppler, if you see the tricuspid annular, the systolic velocity will be less than 9.5. These are the important signs you have to assess. So how to measure the LV-RV ratio? This is very, very important point. More than 0.9 shown to be independent risk factor for hospital mortality. They have studied 1,416 patients. So mortality rate, if the ratio is less than 0.9, that means usually LV is big compared to RV. That is 1.9 versus when the RV-LV ratio more than 0.9, 6.6. Suppose the ratio is 1.5, more than 1.5, it's 17%. So bigger the RV, so the mortality is more. So take the ratio, and if the ratio is more than 1.5, that means 17 versus when the ratio is less than 1, that is 0% mortality. And this patient again, because patient had a right atrial clots, we are concerned, is it only right atrial, right ventricular pressure leading to failure or any pulmonary? You see the pulmonary embolism already it took. So this patient is a very high risk. If that clot enters and if entire MPA is blocked, patient can collapse suddenly. So we gave a thrombotherapy based upon the freely floating. So recommended that anticoagulation is important. Systemic thrombolysis is highly recommended for high risk PE. And if not responding to systemic, you can also consider surgical embolectomy. So when do you want to do the surgical pulmonary embolectomy? If there is a contraindication to thrombotherapy, if you have given thrombotherapy, it's a failed. And if there is a PFO is there, through that it's producing, you just remove and close the PFO. Also pregnancy, a right heart failure, patient is having cardiogenic shock, and thrombus in transit, like this patient, within the right heart chamber. And this patient, so we were having a dilemma. We were thinking like left, because not responding to we gave a thrombotherapy, but it's not the thrombus not resolved. So then is it LA myxoma? That way we were thinking. Then we called surgeon. Here large RA thrombus, pulmonary embolism, hemodynamically stable. So LA myxoma, initially treated with IV thrombotherapy and heparin infusion and respiratory support with high flow oxygen and diuretics. So even after adequate anticoagulants and thrombotherapy, persistent RA-RV pulmonary antithrombus with significant cardiovascular symptoms. Then we thought this candidate is an ideal candidate for surgical embolectomy. So it was performed on 6th day, that is removed the right atrial thrombus and pulmonary thrombus. And he was discharged on 14th day in a stable hemodynamic status with markedly improved cardiovascular symptoms and significant follow-up PA pressures. Now he has been under constant follow and has been taking acetram 3 milligram daily and ecosprin. This is the last case. This is a 25-year-old male, a known patient with congenital heart disease. They diagnosed as a case of PFO, left to right shunt with history of shortness of breath, class 2 to 3, after 2 days. There only 2 days onset of symptoms. And he came to my OP by walk. So then ECG showed sinus tachycardia. ECG was, my HB was 18, WBC 10,000. And then because patient had a severe dyspnea, PFO will not produce that kind of symptom. And there is no other past history of any other congenital heart disease. Then we thought immediately, let us check the echo. He's a 25-year-old male only. Immediately we took him to the echocardiogram. Then while doing echocardiogram, there is a large, almost like a cricket ball size. It's a swirling in the right atrium. It was freely swirling, big right, almost occupying the entire right atrium, freely moving. And we were unable to see the LA. It's compressing also. Such a big right atrium, right ventricle, a good LV function. And immediately after seeing that echo, then we came out and we discussed the family members, and we told them there is a possibility of sudden event. He has to be in the hospital immediately, and we should think of immediate thermal therapy. But they agreed. While shifting, immediately he developed a cardiac arrest. So while shifting only, we did cardiac CPR, intubated. That time only we pushed from pharmacy, we got the thermal therapy, immediately pushed. Then immediately shifted to ICCU, intubated. And almost we continued for 24 hours. 24 hours later, his pressures improved significantly, and he was awake and relief of symptoms. Then we extubated, and he's markedly improved RV function. And on 6th day, he was discharged. And this is a case of massive pulmonary treated with a IV thermal therapy. So this is the appearance of bilateral massive pulmonary thrombosis. You can see sometimes it looks like a saddle thrombus also, extending into the RPA and LPA. And so just now he has shown, so diagnosis of how to suspect the high risk PE. So first and most important, is it hemodynamically unstable? If hemodynamically unstable, first to do the echo, how is the RV function? If RV function normal, rule out the other cause. It may not be pulmonary embolism. So echo plays a very crucial role. If the RV function is abnormal, if you have a CTPA, immediately get the CTPA. If positive, treat it like a high risk PE. If negative, pulmonary embolism not on CTPA, search for other causes. If no, if you don't have a CTPA, straight away you can thrombolize. So if the patient comes under high risk, reperfuse, hemodynamic support. Intermediate group, that is a high risk group, monitor, and if worsening is there, think of rescue reperfusion therapy. If troponin I negative, intermediate low risk, hospitalize and observe the patient. Treat with anticoagulants. And low risk patients and known early discharge. And if there is a family social support is there, you can also consider for home therapy. And suppose a high risk patient is there, hemodynamically unstable, one arm is a thermal therapy. Another term, you have to support the hemodynamics also. Give a volume expansion, still not responding, give a inotropes, norepinephrine or dopamine or dopamine combination you can give. And still, if it is not, you can think of the veno ECMO. That is veno arterial ECMO. You can consider ECMO is now available. ECMO also saves, but this is not the definite therapy. You just give the ECMO. Simultaneously, you have to give a thermal therapy or systemic or aspiration, or you go with the surgical. That is a definite therapy. This is for hemodynamic support. So if you are only giving ECMO without other things, patient will not improve. So as far as possible, avoid mechanical ventilation, particularly if avoid PEEP, that is very important because the venous return will be decreased and it may lead to further deterioration of the oxygen saturation. So these are the different already as shown. I don't want to highlight this one. So percutaneous catheter-direct therapy should be considered for patients with high risk in whom thrombolysis contraindicated or failed. That also you can aspiration catheters you can try. Norepinephrine abdomen can be given as an inotropic support. ECMO may be considered in combination with it. This is not ECMO always when you are thinking of surgical embolectomy or catheter-direct therapy, additional adjunctive therapy. That is very, very important. So these are drugs recommended by the ESC guidelines, mainly to provide. This is Alteplase is already discussed. So Alteplase is more effective. The evidence is very, very supportive. And that's the reason when you give this thrombotherapy, the improvement in the RV function and reconnection of the pulmonary artery and fall in PA pressures, fall in TR is much more significant compared to other thrombotherapy. So whenever it is possible, but don't wait, suppose if this is not available. Whatever is available, you push it. Any thrombotherapy will help. But when you have an option, you try to choose the drug. And the most important, the expedition, the faster the better, quicker the better. That is the most important. Act very fast and involve the respiratory intensive care specialist, surgeon, everybody. This is called PET. So pulmonary embolism response team. You have to involve the surgeon, you have to involve the simultaneously activate the entire system, and you also involve the emergency physician. Wherever patient comes to, he has to give a single central count to everyone, like a cardiologist, interventional cardiologist, anesthetist, respiratory physician, and at the same time surgeon. All will, as a team approach, you can collectively take decision what kind of therapy we should give, whether patient needs immediate thrombolysis, whether patient needs mechanical aspiration, whether he requires any surgical therapy. That is very, very important. So this patient discharged on 6th day in a stable, this is the clot, you can see very clearly, had been taking 3 milligrams acetram and Clavix for 18 months. And 18 months, he improved very significantly subsequent. Sometimes at the time of discharge, you may have some clot, but over a period of 2-3 months, if you check this repeat CTR, most of the time, these clots will dissolve even with oral anticoagulants also. So always vigilance is very, very important. And because he stopped 18 months later, he was feeling very, very comfortable, no symptoms, then he stopped medications. So in 2015, presented with complaints of sudden onset of severe breathlessness, with palpitations and perfusion, and stopped 18 months. And all these patients are unprovoked. They didn't have any venous thrombosis of the legs. Most often, we always search for any venous Doppler study is must, particularly proximal, the thrombus of the proximal veins of the leg. Another one is particularly in pediatric age group, any IV prolonged IV cannula, intrajugular cannula, that also can produce to DVT, particularly prolonged or cancer patient, recent surgery, immobilization, or prolonged stent. These are all the risk factors you have to evaluate. Why this patient developed the recent any immobilization, recent any surgery there, any bedridden, obesity, all these factors you have to think before you treat the patient. So this is the echocardiogram. You can see very clearly. 1 minute, I'll show the echo. This is the final. You see, there is a right at PR is there. Then PA pressure was almost 54, dilated RARV, and there is elevated PA pressure. And then dilated RA, you can see RV systolic pressure. That 54 means you have to add a minimum 10. But in this case, better to add even 20 also, because IVC plethora is there. 65 RV systolic pressure. That means a significant PAH. And this is the acute pulmonary thrombosis involving the interlobar and left distal pulmonary artery with the extension into the segmental branches. You can see the clearly bilateral pulmonary artery thrombi, both sides, CR1 thrombus, and you can see managed with IV thrombotherapy, day 2, post-thrombosis. So immediately results, you can see very immediate, obvious results you can expect. PA pressure fell down from 69 to 49. So 10 millimeters of mercury, and you see right ventricle is again size almost becoming normal compared to LV, it's slightly. less. So gradually, over a period of you see 2-3 months later, this RV becomes normal. TR will subside. That is very important. Once the thrombus is recanalized, so this is the PA pressure. And on day 4th, you can see this thrombus got cleared, and here some residual thrombus. Discharged on 6th day in a stable hemodynamic with fully resolved thrombus and relieved cardiovascular during 1 month follow-up CT, which is not available on regular follow-up without any recurrence of symptom. This patient, because he had 25-year-old unprovoked pulmonary embolism, he has to continue indefinite period, because if he stops for 6 months or 1 year, recurrent chances are very, very high. So almost 3 years he has been taking. Now there is no recurrence. So I told them not to miss these tablets for them because they are very high risk. So ventricular thromboembolism clinically presenting as a DVT or PE is globally third most frequent acute event. And thrombotherapy is recommended in all patients with high risk PE unless contraindicated. And the intermediate group, if there is a worsening or any deterioration is there, that time you can worsen. So routine use of primary systemic thrombosis is not recommended in patients with intermediate or low risk PE. Assembly of a PET, that is, I told them, pulmonary embolism response team. That is, in every hospital, they should form a team involving the chest physician, involving the anesthetist, involving the surgeon, involving the cardiologist, interventional cardiologist, and emergency physicians. So they should form a team, and they should immediately exchange the CT films and echo films, and they should together, they can collectively, they can take the appropriate treatment strategy, and based upon his risk profile and based upon his clinical condition. And I think that will make a difference. Thank you one and all for paying the attention. Thank you very much.